But I'm here to talk about diabetes and prediabetes, and especially concentrating on the Latinx population, but also just a global discussion of who we should be screening and what we can do to reduce our risk and what we can do in terms of medications as well. So we'll talk about the definition of diabetes and prediabetes, estimates of how frequently these diseases are in our community. We'll talk about who should be screened and the importance of health behaviors we want all of us to promote in our communities, and also a little bit about treatment. So, a definition: prediabetes, we can diagnose diabetes or prediabetes with the same test. One is a hemoglobin A1C test. It's a blood test, and that measures how much glucose is attached to a molecule called hemoglobin that's in our blood. And a value of 5.7 to 6.4 with no previous history of diabetes is consistent with pre-diabetes. So 5.7 to 6.4. Hold on one second. Hey.
It's just like, are you okay?
We have to get everything done.
Hold on one second.
Yeah.
Okay. All right. And let me share my slides again. Hold on one second. Can y'all see my slides? I don't think so.
No, we can't.
Okay. Sorry about that. Okay. And another way you can test for diabetes is a fasting glucose. So a value between 100 and 125, if you don't have a history of diabetes, is consistent with pre-diabetes. And then in terms of diabetes, an A1C over 6.5 or over is consistent with diabetes. A fasting glucose over 125 is consistent with diabetes, and a random glucose over 200 is consistent with diabetes. Now, sometimes you can do a glucose tolerance test, but that is a 2-hour test that requires that you come fasting, and then you have to drink a sugary drink. So if you can get diagnosed using this one single blood test, that's easier than having to go through a 2-hour oral glucose tolerance test. The prevalence, so prediabetes is very, very prevalent. 98 million Americans, 1 in 3 Americans we think have prediabetes. Most of them don't know they have it. 34.5% of people with Hispanic or Latin heritage have prediabetes. In terms of diabetes, 38 million Americans, 1 in 10, have diabetes, and we think 6.9 million, about 15% of people with Hispanic or Latin heritage have diabetes. Prediabetes converts to diabetes at a rate of 10% per year. And what's really important is that diabetes can be prevented with 7% weight loss, dietary changes like increasing green vegetables and maintaining normal carbohydrate portions, not excess, and exercise of 150 minutes per week has been shown in clinical trials to reduce the risk of diabetes. And medications like metformin and GLP-1s can also prevent diabetes. This is prevalence of diabetes in North Carolina. And if you want to look at other health disparities, I will send out this PowerPoint, and it can be distributed. And here's the link to this health disparities analysis report. And you can see that of the total population in North Carolina, 11.2% of patients have diabetes compared to, if you're just looking at the white non-Hispanic population, it's 9.3% of patients have diabetes. In the African American non-Hispanic, it's 17% of people with diabetes. And in the Hispanic Latinx, it's 13.8%. So there's a disparity there in who is getting diabetes. So let's talk about who should be screened, and we can go back to these slides if y'all have questions. So any adult with, that means over 18, who has a BMI over 25 and has one or more of these risk factors. So a first degree relative, a high risk racial or ethnic group, which includes African American, Hispanic, Latinx, Native American, Asian American, or Pacific Islander. History of heart disease, hypertension, a low HDL cholesterol. HDL is your good cholesterol. If it's low, it's concerning that you might increase your risk for heart disease. And then women with polycystic ovarian syndrome, if you're physically inactive, symptoms of insulin resistance. If you already have prediabetes, you should be screened for diabetes. People with HIV or a history of pancreatitis. And we recommend that patients are screened at least every 3 years if they fall into these risk categories. And then everyone should be tested for diabetes starting at the age of 45. So this is the top part of this screen is 18 and up. If you're overweight or obese and have one more risk factor, and then if you're over 45, whatever your risks are, you should be tested every 3 years. If you have pre-diabetes, or if you have a history of gestational diabetes, you should be screened every year for diabetes. Some of the things that can help prevent pre-diabetes from going to diabetes, or can prevent diabetes from getting complications like stroke, heart attack, kidney disease, are the following. So exercise, 30 minutes, 5 times a week. And it doesn't have to be super strenuous. You just want to get your heart rate up a little bit. So a walk, a stationary bike, a real bike, or any kind of exercise that a person likes to do, 30 minutes, 5 times a week. Stop sugar sweetened beverages like soda, reduce alcohol intake. A lot of folks don't realize that for women, more than one alcoholic drink per day is dangerous. And for men, it's more than 2 per day. So that's 7 per week for women and 14 per week for men. And then smoking and diabetes do not mix. They increase the risk of vascular disease. Hold on 1 second. Let me just tell these people to be quiet. Hold on 1 second.
Well, she's, oh,
Sorry, I'm so sorry. I did not realize I was not going to have a place to sit except for this lobby area. So I'm telling people to be quiet. I'm very sorry about that. The other thing is obtaining adequate sleep. So lack of sleep causes increased cortisol, which is a stress hormone, and that stress hormone increases glucose. The other thing I want to really promote is everyone should know what your numbers are. So know what your A1C is, know what it means, know what your glucose is, know what your blood pressure is, know if you need screening, know how to interpret the numbers. And then medications, definitely if your doctor recommends a medication and you're concerned, please ask questions. And if you're having any side effects, please discuss with your provider. And if you don't feel comfortable, you can discuss with the nurse or the pharmacist in the clinic. if there is one. Okay. And then I just want to talk about quickly the medications you might hear that people are taking for diabetes. Metformin or glucophage is a pill, and we really recommend that we start this when your A1C is 6.5. It is inexpensive, and the main side effect is it causes gas, bloating, diarrhea, for the first weeks that you're on it, but it will go away if you stop the medication, the symptoms will start up again. Metformin cannot be used if there's any kidney damage, but it does not cause kidney damage. It just can't be used if there is kidney damage. Sulfonylureas, that's medications like glimepiride or glipizide, also inexpensive. The main issue is that it can cause hypoglycemia. It works by increasing the amount of insulin that is secreted from your pancreas. GLP-1s are these new meds. You probably see advertisements for them on TV. Ozempic or Trulicity are some of the name brands. They're very expensive. They do cause nausea, vomiting, weight loss. They cause you to feel full. They might be linked to pancreatitis. But if you need to lose weight, they're very good at helping patients lose weight. And not only that, they can reduce the risk of kidney disease, heart disease, and stroke. But they are very expensive. Insulin, there are many different types of insulin. It's required for people with type 1 diabetes. That's when your pancreas is no longer making insulin. We used to call it juvenile diabetes because we saw it more often in kids. Now we know that type 1 diabetes can occur at any age. And one thing we should all know, it's an emergency if the patient with type 1 diabetes is out of insulin. This is something that I'm very worried about with people out in Western North Carolina. If they rely on insulin and they lost their insulin because of the storm, I do have some phone numbers and contacts for that if people need it. Walmart does sell regular NPH and 70/30 insulin for $25 a vial. A lot of the designer insulins are much more expensive than that. But if it's someone is really in an emergency, they can get this old-fashioned insulin at Walmart, and it does work to keep patients out of the hospital. SGLT2s are a pill. It basically pulls glucose in the blood into the urine and out through the kidney. It can cause very serious urine or skin infections, but it also reduces the risk of kidney failure and heart failure. And these medications, though, are also very, very expensive. Thiazolidine that's something like Actose or pioglitazone. It's a pill. It improves your body's sensitivity to its own insulin, but it does cause more weight gain, fluid retention, and can exacerbate heart failure, but it is inexpensive. So I'm going to stop there and take